Okay, yay. So tongue ties and frenectomy. I think this is probably one of the most overwhelming parts of the puzzle. So you guys found this out a little bit with the comprehensive exam. Like there were a ton of questions relating to the tongue tie. So we're going to get into that. So we're going to be going over tethered oral tissue, so a tongue tie, signs and symptoms, what it looks like through the lifespan, why it's a concern. We're going to talk about Dr. Zoggy's 5 dimensions of a tongue tie, and then how to calculate the TRMR, which stands for tongue range of motion ratio. Okay, so last time we learned about the comprehensive exam and the symptoms. So now we're going to just build on that a little bit more. So what is a tongue tie? So hopefully the dog's settled down. My sweetie's just getting home. So some people will call it a tongue tie. Some people will call it tethered oral tissue, but this anchors the tongue down and keeps it from reaching the palate where it naturally stimulates the maxilla development, okay? Also, the Mayo Clinic says it's an unusually short, thick, or tight band of tissue, the lingual frenum, that tethers the bottom of the tongue to the floor of the mouth. So the problem lies with the fact that there's not a lot of training to identify and educate about tongue ties, okay? Tongue ties, and ULT is upper lip tie. So it needs to really be taught in schools more. We need to teach OMT in schools. We need to talk about how the jaw and the lips and the face, the tongue function, and why we as hygienists should lift and look. So I will tell you this, the USA is really behind the times. Brazil is really forward thinking, and you're going to find a lot of research and stuff does come out of Brazil. They have the Teste de Linguina law. Sounds like pasta to me. This law screens for tongue ties in every newborn. It's just a law. Okay, so Connecticut tried to pass this. It didn't pass. And oftentimes we always say, gosh, it would be really awesome if we weren't helping people understand about tongue ties, if they were just looking at them when a baby is born. The thing is, you guys, is it's not like a pregnancy test. It's not just a positive or a negative. It's kind of like spiciness. So that's what Dr. Zoggy says. So that's the tricky thing. So I always say when we start having laws, like who's going to enforce them? Who's going to be the one that says, yes, this is a tongue tie, no, this is not a tongue tie? Because you're going to find there's a lot of variation, okay? I'm trying to see, I see Stephanie keeps trying to come in, but it's not letting her into the room. I'll watch for it again. Sorry, I'm letting more people in. There they are. Okay. Oh gosh. Okay, tongue tie. You guys can see my screen, right? I'm sharing. Wouldn't that be terrible? I hope somebody would say, hey, Carmen, your screen is not showing. Okay, tongue tie. So it can be partial or full. I never use the words partial ankylglossia, but that's the technical term. It is an embryological remnant of midline tissue. So it is a minor midline birth defect. You will hear a lot about the MTHFR genetic mutation. I definitely do not get into that with my clients, nor do I really get into it so much with my education and training, because the MTHFR gene mutation can cause like 65 different conditions. So if people have questions, I say, hey, Google has a ton of information. Yes, it's related to a tongue tie, but that's about as far as I go. A tongue tie is present very early in utero, and it is also, some people call it the frenulum, some people call it the lingual frenum. So there's some types. So you've got normal, you've got anterior, you've got short and anterior, and you've got ankylglossia. So total ankylglossia is when there is no movement, the tip of the tongue is tied down, okay? I often say we have to use some common sense on those. I just tell my clients it's too short, it's too thick, it's in the wrong spot, okay? Eiffel Tower appearance, so it has legs that will kind of fan out. So you can see here in this picture how as the frenum approaches the alveolar ridge, that the legs fan out. I have had clients that have had canine to canine Eiffel Tower. So it's just like a big fan. Again, here it is. Common sense with tongue ties. Too short, too thick, in the wrong spot. Okay. You don't have to get too worried about it. When in doubt, let the doctor decide. But you can also still identify all of the, the OMDs and start therapy because you can help. So what happens a lot of the time is students will say, oh, I just have no idea if this is a tie or not. Hey guys, if you've got noise, will you mute? So students will be wondering if it's a tie or not. And I always say, well, you can refer to have it looked at, have somebody assess it, because the doctor's going to assess it anyhow, because they're the one doing the procedure. They're the one that has to agree, that there is a concern. So, but you can do that and say, hey, I'm going to have you, have it looked at. But in the meantime, yes, we can start therapy because you need me for mouth breathing and you need me for swallowing, all of those things. So don't let that just be the end of like, oh my gosh, what do I do? Still identify how you can help them. Okay. So it's important for you to know who has a tongue tie and why. So it's a genetic thing. Okay. Anybody can have it. Why it really matters. So it will be really important that you're able to explain that. Why does it matter? Because it's going to affect the craniofacial development. When to treat it. We're going to be talking about this. Is it a new fad? I did 5 exams yesterday, and every single one of them said, why am I just now hearing about this? Is this a new thing? It's not. It's been around for years and years, but it's being found more because more people are breastfeeding. And then also, different people have different sensitivities to a tongue tie. So you may see somebody who doesn't seem like they really have like they're not very reactive to their symptoms. And you look at this tongue tie and you're just like, oh my gosh. And other people, they barely have any restriction and they're really sensitive to it. So everybody's going to be a little bit different. So signs and symptoms. A sign is objective. So it's measurable, it's quantifiable. So like when we're looking at the measurements that you take, that's going to be objective. A symptom is subjective. So everybody's going to be different. I've talked with you guys about those complex clients that are just complex because maybe up here they're complex, though they're going to have a lot different explanation of symptoms because they're subjective. I always just type in what the client says, and you'll have clients that say crazy things. Like when I lift my tongue, I feel it pull on my pubic bone. I'm like, that's a really big tongue tie, Also, the tongue tie and a tongue thrust have similar symptoms. The tongue tie is a physical barrier that you just can't correct. And then the tongue thrust is a learned behavior. Things to remember: the ability of the body to compensate for the tongue tie does not justify inaction. So there's going to be a lot of people that are like, well, whatever, he's fine, or I'm fine, I've made it this long. I mean, with adults, they get to choose, but I really try and educate parents on just because Johnny's doing fine now, that doesn't really justify saying, hey, we don't need to do anything. Those compensations have negative downstream effects. So there are consequences of ignoring it. And that's what I always tell parents. Parents seem to respond to the word consequences because, they use it with their kids. Hey, that's a consequence of your decisions. I make sure that parents understand the consequence of ignoring a tongue tie or ignoring the mouth breathing. So rather than saying that's the way it is, doctors and practitioners should be asking themselves, like, why is this human doing this, this, and this? Why can't the person open very wide? Rather than just say, oh, you have a tiny mouth. Why is the mouth so small? Why? Why is there space between the teeth? So those are the questions that we should start asking. Compensations fall away. So over time, you're going to see symptoms increase. People are going to say, I have no idea what changed, but in the last 5 years, my whatever insert symptom here has started to change. So I always tell people, yes, things are going to get worse. And then do no harm. When we do no harm, we doing nothing is doing harm. Okay. All right, I've said this before. So as the hygienist, you guys are the agent of change. Not all tongue ties are going to look like the classic heart shape or the classic butt tongue, as I always call it. Posterior ties are harder to identify, but potentially cause the most problems. We're going to be looking at that today. Many specialists, sorry, I got to keep letting people in. Oh, I'm back here. Many specialists will tell clients that they don't need a frenectomy, even when speech and swallowing issues are there. So it's really disheartening. When that happens to you guys, it's more than anything, it's just going to piss you off. And when that happens, you can't change that person. We don't educate idiots, okay? But when that happens to me, I resolve to connect with and educate 10 more people, because that's how I can make a difference. I can't change the jerk's view, but I can change how I educate other people. This is one reason why I encourage a comprehensive exam before they have a consultation with a doctor, so that they are armed with information about their dysfunction. I have clients take their report, and when the doctor says, no, I think you're fine, she's like, oh, but Carmen says I'm not, because I've got 8 pages here that say exactly why this is a concern. So that's why I want people to see me first. In my marketing, in my social media stuff, you'll always see me saying, hey, I'm the first place. I'm the tour director. I'm going to plan your travel itinerary. You want to start with me. You are often also going to be the first person that somebody talks to, that you talk to about a tongue tie. It's going to happen. Okay. So be prepared to talk about it. And in your office, I encourage you to start a protocol to screen for tongue tie and tongue thrust in children and adults. So one thing, when is a client ready for a release? So a client is ready for a release when they can separate the floor of the mouth from the tongue. Sometimes this is harder than it sounds, because we want them to be able to move the tongue without pulling on the floor of the mouth so that they can heal correctly. The appropriate pre-procedure therapy when it has been completed, then they're ready for a release. This is generally 6 to 8 weeks. This varies from provider. I settled on 8 to 12. So I'm about at 2 months right now. Some people need a little bit more. Dr. Zoggy's protocol is a month. The reason that I set my standards a little bit higher than his is at the time I had so many clients coming from other countries, and they were traveling, or even if they're traveling in the United States, they hop on a plane and they come to Denver to see my provider. The last thing that I ever want to happen is that they get there and they're told they're not ready. So I also think it's a great sweet spot, because I have providers call and say, I don't know what the hell you do, but your clients are bomb diggity ready. I had a client have a release with Dr. Zoggy not too long ago, and she told me that Dr. Zoggy brought his whole team in to look at how prepared she was for her release. So that's what I go with. And I always tell people, oh, you only want to do therapy for a week because you're having a release next week. I won't work with them. And my explanation is because I have an international reputation to protect, and I want to sleep at night, and it's not going to be successful. So that's my protocol. It's a little bit more than others. I also, you guys, I have had clients who have jumped ship from another therapist and came to work with me. That therapist had done 12 sessions of therapy and had not yet even talked about the tongue tie release. It just seemed like the person was just wasting time. My point is, I want everything to be effective, and I don't want to teach you to run after you've got new sneakers. So I do what I can to get ready, or my main focus is to get them ready for the release, and then we do the rehab after. Okay. So if there is a severe tongue tie, so this says, depending upon the severity, therapy might be limited to awareness building during the initial 4 to 6 weeks, 4 to 8 weeks. I work on breathing and awareness. Once the frenectomy is done, then I will spend a couple sessions working on the pre-procedure stuff. And we're going to talk more about a 2-stage release. So that's what that means, is if somebody has such a severe tongue tie, then we have to do that in 2 stages. All right. So how do you approach the symptoms? You need to understand the symptoms and also here's common sense, look for anatomical reasons if conventional theory isn't working. So just because something says that it should be this way doesn't mean that. So common sense. Waiting should not be an option. Unfortunately, it is, but then an age-appropriate release becomes an issue, and we're going to talk about that. Craniofacial growth can be jeopardized, breathing can be jeopardized, sleep can be jeopardized. So tongue tie has a lot of problems, okay? We do not identify it by a photo. It is not appearance alone. Function is what counts. Pain and discomfort are also good guides to go by. Common sense again, and then there's also what I call the low-hanging fruit. So those are probably the tongue ties that you guys are used to seeing. The ones that look like the classic butt tongue, or they're really bad, okay? I have lots of clients where pain and discomfort are the one thing that push them, and I say, you're doing pretty good. You don't have a ton of mobility issues, but they've got tension and aches and headaches and all that stuff. And those people are the ones saying, hey, yeah, I understand that you don't think I need a release, but I would like it. Okay. So here's all the signs and symptoms for an adult. And this probably isn't even all of them. So I'm not going to read them all off, but on your discovery paperwork, you're gonna see the connection here, okay? The biggest thing, actually I have a slide, we'll get to it. So tongue ties tend to get missed in bottle-fed babies until later because breastfeeding challenges aren't identified. So that's a big one. Speech is not always affected. If the mouth is opened, speech is going to be distorted. Correct tongue position and improved tone will help articulation. I tell people all the time, especially the people with children in failed speech therapy, half of the muscles in the tongue are responsible for shape, half are responsible for placement, and we have to have the tongue able to do its movements so we can have correct articulation. And the tongue is not providing internal support for the maxilla, so the palate is high and narrow. We want it to be wide and shallow.